and we are there for your help. So now what I have done, on a short notice, I have just created a review type of PowerPoint. So the plan is like that. Today I will be going over this review session, and on Tuesday, same time, I expect you will be sending me questions. If you have even further some issues, something which you want me to discuss out with you, so you can send me the questions, and then we'll spend good time to be going through with the various things and various concepts which are really mandatory for that. So now let's start. And there you're looking at these bones, and these are called clavicle. So now from this clavicle, what is expected from you, that you should be knowing it. So let me make it a pen, I think that's better. So from this clavicle, what you need to know, on top of the list, you need to know that the site where is most commonly been fractured. So that you can see from the medial two third to the lateral one third. That's the place where is the weak, where the my clavicle is weak. So that's the fracture site on both the sides. Are we good? And you can see that one end is quadrangular and the other one is other end is flat. So this flat end is designed that this bone will be articulating with the acromion process. And this end is going to my sternum. Okay, so I don't think you need to know anything further than this about clavicle, that what are the weak point and its upper surface, and that's all theory. I don't see any rocket science in that. So let me proceed further. But what you should be knowing, that once the clavicle is fractured, why, you know, why it is my limb has behaving differently, and what are those factors which are happening, that we need to be connected at. Now coming to this scapula bone, if you're looking at this scapula, this is its anterior surface and that faces my body, and this is from the back. And on the back you're looking at this structure, we call it spine, and above to the spine we had supraspinatus fossa, and below to that we have infraspinatus fossa. And now these spinous fossas are primarily a muscle which comes from here, goes all the way like that. That is my supraspinatus. Now what I need to know from supraspinatus, guys, this is an important muscle for initiating my abduction. And then infraspinatus is another rotator cuff muscle. And this surface, what do we have? We have here a muscle called subscapularis. And there on this border, we have attachment of a muscle called serratus anterior. And I'm sure all of you have seen it. This is my coracoid process. And this is the acromion process. And that's the glenoid cavity. So now, this is just an intro on these bones. Now humerus. Humerus, what you need to be good at. This end, we all know this is head. These are the tubercles, the greater and the lesser tubercle. But what is must know thing, this is one of the site of fracture. We call it what? We call it surgical neck. This part is called surgical neck. And what you need to know out of this, that what are those important nerve and artery which are related here. If you know that, let's say if you are given an x-ray which is showing a fracture at this place, fracture of my surgical neck, so then you should be understanding that we are talking about. So we will provide you some infos. Either they will be connected to this nerve or they will be connected to this artery. So then you have to figure it out. If let me give you an example. If this is a fracture here, axillary we are talking about, then the link will be, clue will be something about abduction. So some problem with the abduction or loss of sensation where over the surface of the deltoid. Are we clear? Then mid shaft. At this mid shaft, if we look at, this was the anterior view and this is the posterior view. Now I like you to look at this posterior view. Guys, on the posterior view, you can see that there is a space, there's a spiral area, there's a groove. We call it radial groove. So on this radial groove, what do we have? We have what? We have the relation of a nerve and an artery. Who's the nerve? Radial nerve. And who's the artery? Profunda brachii artery. So they are at risk. Now, a question which always bother you, and that question is that there are other structures, other nerves they are also passing, and some of the books are talking. People are talking about why not brachial artery? Yes, brachial artery is going close. But what I'm trying to say, these structures, what are these structures? The radial nerve and profunda brachii artery. They are literally running in this place. So they are the first structure to be damaged if I have a fracture here. But anything which is close by, that can be a secondary structure. Ulnar nerve is passing, median nerve is passing, but they are not closely associated with this bone. So you have to understand how you can interpret these things. And then definitely you should be going for the links, that if I'm talking about radial nerve, I may be talking about something like what happened to the extensors, what losses, what effects you'll be seeing on the wrist. So these things should be very, very, very clear. Then coming down, same bone here. These are what? My medial condyle and my lateral condyle. So above to them, this is a supracondylar fracture. So I talk about three fractures: a fracture of surgical neck, a fracture of mid shaft, and a fracture of supracondylar region. So there, if this is involved, again a nerve and an artery, but they are changing now. Which nerve? Median nerve. Which artery? Brachial artery. So they are the more susceptible. Are we good? Perfect. Now, if I talk about, there is a fracture of this medial epicondyle exactly at this place of going. That is my ulnar nerve. So if we talk about fracture of the medial epicondyle, so you should start thinking about the damages occurring to the ulnar nerve because it's very close. And then the findings will be telling you that what is happening. Are we good? So you need to be looking at this bone in different perspectives. Are we clear? Any question related to that? Any person who's not clear? Guys, I need your anything which is not clear. Anuj, can you help me with that? Anybody is asking any question? Because I like to take question with the stuff. Yes.
Yes, I can hear you, doctor. Just a minute.
Yeah. So, are there any question? Is there anything that bothers people?
Yes. What happens when ulnar nerve get damaged?
Okay. So we should know what are the areas where ulnar nerve supply. So ulnar nerve primarily supply in your hand. So the movements of my hand muscle, intrinsic muscles of my hand, they will be impaired. And we had a classic type of hand. We call it ulnar claw. Can you see? Can you look at my hand? The hand will go like that. That's a classic of an ulnar claw. We all know ulnar nerve is innervating what? My two, digit fourth and digit fifth. What? The flexor digitorum profundus. So that will not be functioning. My lumbricals, 4 and 5. I'm sure you don't know about lumbricals. We'll be talking tomorrow in the lecture of the hand. So my hand go in a very classic position, and that's called the ulnar claw. And that is a classic of the ulnar nerve damage findings. Anything else?
Yes. The artery damaged at the
Any other
supra.
question?
Yes, doctor, can you hear me?
The artery?
The artery
Yeah, yeah,
damaged
I can
at
hear you. You,
supra.
you continue talking.
Yes. The artery damaged at the supracondylar fracture is brachial artery.
So the artery which will be damaged, if artery is damaged at supracondylar fracture, that artery is my brachial artery. And then we have what? What finding we might find? Any idea?
Medial
Walkman's
nerve.
ischemic contracture. We'll find Walkman's ischemic contracture. Word ischemia is connected to blood supply. Walkman's ischemic contracture. Anything else?
Uh,
Doctor, the artery that is damaged at the shaft is the brachial artery or the profunda. I have mentioned before and I'm saying again, at the mid shaft, the first thing which can be damaged is the profunda brachii. Reason, profunda brachii is going very close to the bone. And the brachial artery is away. Brachial artery can be damaged, but the first thing first. So profunda brachii is the first thing which can be damaged. So with the medial epicondyle, the ulnar nerve. I'm not talking about ulnar artery here. Ulnar nerve is the more prone structure. Can you repeat what causes Walkman ischemic contracture? The ischemia word means the blood supply has been gone, so the brachial artery. How it is presented, I will show you this Walkman ischemic hand picture tomorrow because that's a, yeah, this Walkman spelling is right. In the epicondyle fracture, ulnar nerve. How about anastomosis of the brachial artery? Are they involved? Yeah, it depends because we have to identify where the fracture line is going. If it is here, there will be a different presentation. If it's here, there will be a different presentation. If it is involving any of the anastomosis site, then we'll have a compromise in the flow of the blood. What is the effect of the mid shaft fracture on the wrist and the hand muscle? Obviously, mid shaft fracture, you are losing which nerve? You are losing radial nerve. So, radial nerve controls the extensors. And where are the extensors? Extensors, the radial nerve is not supplying in a big way to the muscles of the hand. The muscles of the hand are primarily innervated by median nerve and ulnar nerve because the radial nerve, when it reaches to my hand, it is almost done. It is finished. And what I'm left with is sensory part only. Yeah, the fracture may damage. It's not always damage. Clavicle fracture, what movement can be what movement affect in clavicle fracture? When your clavicle fracture, you cannot move your shoulder. You have painful, it's really painful, and I think everything will be affected. Flexion, extension, abduction, adduction. You can do it, but you can do it with quite a lot of efforts. Is the supracondylar fracture or medial epicondyle fracture that affect the ulnar nerve? Usually not. Medial epicondyle is the one where ulnar nerve is more at risk. Brachial plexus, right? For what? Noor, you're writing brachial plexus. For what sense? Clavicle, yes, it can damage. Yeah, clavicle fracture, if it's going deep in, it may damage the roots or the divisions or the cords of my brachial plexus. Anything else? The fracture of the mid shaft affects the radial. Yes. Any other question? Can I proceed further or you want me to talk something else? Okay, fine. So I'm going further. Let me minimize this one, close it rather. Okay, guys. So now we are looking at these bones, radius and ulna. Now for radius and ulna, you remember I have posted one question in the discussion forum, and it was about pulled elbow. And for the pulled elbow, you are writing half answer right and half is not right. Pulled elbow, this head of the radius pops out of the annular ligament. Remember, I asked in specific from early age, preschool age, what happens? This annular ligament is very loose. It's not head is not developed. Annular ligament is very loose. So there are fair enough chances that it might pops out if someone applies a sudden pressure. Then what else is there? Then we have to talk about the fractures. They can be mid-shaft fracture. There is no any associated finding. But Maha, what are you writing? You are putting a line on the screen. What do you want me to show? Intraosseous membrane is here. I like to see your chat. What are you writing? So in the chat, pulled out elbow affect the proximal radius, not the elbow right. Obviously, proximal radial ulnar joint, not the elbow joint. They are different things. This is my proximal radial ulnar joint. And guys, this one, let me get a pen again. Where are you? Here you go. So guys, at this place, we have distal radial ulnar joint. And at this place, we had proximal radial ulnar joint. Is any nerve damage due to pull elbow? Usually not. The correct answer is the annular ligament is loosened. Perfect. Should we know where the arteries start appearing? What artery? What is the main difference between dislocation and separation? Dislocation means something pops out of its place, and separation means something is separated. Separated, if something is going away. Let's say this head of the femur has come to this place. That's fair enough to be said as separated. But dislocated, it can go a little bit up and down. And you're right when you wrote that dislocation is when the head of the humerus pops out of the glenoid. Excellent, that is a dislocation. And separation, usually, the different terms we use differently. Separation, we use it for clavicle. Let me draw it for you. Now, clavicle is anchored by certain ligaments with the structure below to it. There is my coracoid. Just see to it first. Don't write me any other question. I'm just focused here. So now this clavicle, when there is a trauma, so there is a rupture here. There is a rupture here. What are these ligaments? Coracoclavicular ligament. So my clavicle is now free riding. It's floating. So now we call it separated. Can you please mention some common fractures of the radius and ulna? It can, there are no specific name. If you want me to go for names, then it will be problematic for you. There are so many names, but I don't want to go in intentionally going in those names, but it can be fracture at different location, and there are not specific, like there are names, but not needed at you at this level. So it can be fracture at any of these lines. Montegia is one of those example, but again, don't invite a trouble. Clinical term that presented in the clavicle separation. Doctor, what should we know about the radioulnar joint? Excellent. So let's stay with that. Radioulnar joint, you should know proximal radioulnar joint, what type of joint it is. Then what is the name of the ligament which is responsible. Then the distal radioulnar joint, and then you should be knowing what movements are occurring. The axis of the movement, for that axis, let me use the eraser thing first because I have done enough drawings. So let me erase everything from here. Here you go. Now I'm taking the pen thing again. So now the question was, what was the question? Intraosseous membrane is here. The axis of the movement for this proximal or this distal radioulnar joint is the vertical or the longitudinal axis. So how many ligaments in radio ulnar joint? You can see there are three. Can you please repeat the three ligaments in radio ulnar joint? Yourself. Are we good? Can we proceed further? So if we write the head of the radius is not fully developed, it will be wrong. Yes, the annular ligament is not fully developed. Clavicle fracture, damaged subclavian artery, possible. Subclavian vein, possible. Supraclavicular nerve, possible. Infraclavicular part of the brachial plexus, possible. Annular ligament is not the ligament, because when we talk of the elbow joint, it's a complex. There are three articulation. One is between head of the radius and ulna. Second is between capitulum and the head of the radius. Third is between trochlea and the ulnar notch, and the trochlear notch or the ulnar notch. So there are three types. So the upper two, between the humerus and the radius, this is called inclusive in the elbow joint. And this one between the radius, head of the radius, and the ulnar notch, this is called between the radius and ulna. So you should able to understand pivot. Yes, excellent. Longitudinal axis during pronation, supination, excellent. So this fits in my proximal and distal radio ulnar joint. What about oblique cord ligament? Ignore it. It's too much for you. Not needed. Don't bother for that. Are we good? Can I proceed further? I've just said the ligaments in elbow. Can we consider the annular ligament as one of the elbow ligament? No, that is a ligament of your proximal radial nerve joint. Could you please explain the effect of damage on the radial nerve in regard to extensor of the hand? Obviously, extensor of the hand are gone, then you will be losing what? The wrist drop will come if the radial nerve is gone. That's the simplest explanation. They are recorded. What kind of pain do person feel if there is a winging of scapula when pushing? Person will never feel any kind of pain. It's just a wing starts appearing. Let a wing start coming out of your body. I wish I can bring those 2 3 students which are there at Al Faisal. They are living with winging of scapula. One of them is in now fourth year. I'll bring him for you. I'll show it to you, and you can talk to him. He has no pain at all, because winging of scapula is not associated with any, it's not established. Can we repeat the anterior and posterior ligament? What anterior and posterior ligament? Did I talk about any anterior posterior ligaments? In what perspectives? Can you elaborate your question? Rila, Hamur, you're asking about anterior and posterior ligament. What are these? Where we learn about these? What kind of pain do any person feel if there is winging of the scapula? There is no specific pain for that. Of the ulnar collateral ligament, or you can name it, lateral and medial. So this is how you can see that. So we have three ligaments in elbow joint. Yes, in elbow joint we have primarily, when you are asked about any joint, name its ligaments. So let's say for elbow joint, you have radial collateral, ulnar collateral, and the fibrous capsule. These are the three ligaments of your elbow joint. If somebody asks you what are the ligaments of your proximal radial ulnar joint, that is the annular ligament. Radial nerve damage at different places has different effects. Obviously, I'll be talking about these nerves, and I have something for you. Can you please repeat the three parts of the elbow? It's not three parts of the elbow. Basically, the humerus articulates with ulna separately, articulates with radius separately, and these joints have their names. And then the radius articulates with the ulna in the upper part, and in the lower part they are called proximal and distal radial nerve joints. Is the elbow joint and the proximal joint in the same capsule? Yes, they are sharing the same capsule. Are we good? Can I proceed further? What about the ligament of the distal radial nerve joint? There is no any specific named sort of thing. They are just fibrous bands, and there's not much talk about it. What is the effect of damage to the posterior interosseous nerve on the hand? I just said it right now. It will be landing up with the wrist drop, because I cannot explain extend my wrist. So if I cannot extend my wrist, this is the extension at the wrist. If I cannot do it, this is wrist drop. What is the third ligament of the elbow ligament? I told you, first is radial collateral, ulnar collateral, and the fibrous capsule. These are the three ligaments of the elbow joint. Annular ligament is the ligament of my proximal radio-ulnar joint. When the fracture affect the median nerve, when the fracture, we are not supposed to know the structure that will be at risk if there is a fracture in the forearm. I didn't get your question. Can you write it again? So there is only three ligaments at the elbow joint and not four. No, there are only three. Do we have to know all the arteries and veins we took? Yes, you have to know all. Guys, whatsoever we teach, we will ask you in the exam. If we don't teach anything, we'll not ask in the exam. So we teach you something, we'll ask you in the exam. Make it very clear. Anything which is taught should be asked, should be part of the assessment. Yes, we have to. What is Abdurrahman? In Kohli's fracture, let me come to that. Dorsally displaced hand means how it will look like. I will be talking about that. Don't worry with that. The fracture will never affect median nerve. It can affect median nerve. If you mean the muscle, yes, we have to. Dinner fork deformity in Kohli's fracture. Guys, I told you about the Kohli's fracture. I'm ready with that lecture. I'm uploading that and you'll listen to that. And tomorrow you'll be asking me question about that and I'll be explaining to you. Can you explain the boundaries of cubital fossa? Yes, I will. But please send this question to me. I will bring. I think I can show you right now. I have one of the slide where I can show you the cubital fossa boundaries. Can I proceed or still you have questions? Okay, I'm proceeding because most of you are saying yes. Okay, khalas, I saw that you on me. So now this is you're looking at what? You're looking at sterno. This is sternum, sternoclavicular joint. That's it. You need not to. So what type of joint is this? We talk about that. So now let's talk here. What is this? So guys, now you're looking at anterior chest wall. You can see that on this side you're looking at a muscle that is called my pectoralis major. Pectoralis major, fibers are joining from different direction. You can see that. The upper slip, this one, clavicular fibers. These are sternocostal fibers. They merge, they blend, and they are going to my humerus bone to be attached there. Down, these are the abdominal fibers. They are connected to one of my muscle of the abdomen, external oblique. So my pectoralis major, you should be knowing its action. You should be knowing its nerve supply, lateral medial pectoral nerve. Now this muscle is coming from the clavicle, coming from the sternum and the ribs, coming from the costal cartilage and coming from the external oblique muscle. And all these fibers, they converge to a point and to be attached where my upper shaft of the humerus, that is proximal and distal attachments. And then you should be good at with its action, and that has to be very, very clear. This is one of the very important muscle. When we strip this off, underneath you'll find what? You'll find this muscle. And that's my pectoralis minor. You can see that it comes in serration, rib, upper ribs is being attached and it's going to the coracoid process. Which part of the coracoid process? The lateral aspect of the coracoid process. Now look at it. There you're looking at this muscle, and that's what my deltoid. So you should be knowing about deltoid, its nerve supply, axillary nerve. It is the prime abductor of my shoulder joint, and its work starts after 30 degree or 20 degree. So from 30 till what? Till 90. Are we good? So that's the job of this. And now you're looking at trapezius, levator scapulae, sternocleidomastoid. Now there is my biceps. Look at this biceps. Biceps has been shown. After 90 degree, serratus anterior, levator scapulae, trapezius, they all work together. I think you were explained during structure of the week session. Ayman was talking about rotation of the scapula. If you understand the rotation of the scapula, then you will understand the movement beyond this point, beyond 90-degree. The further abduction will be due to action of trapezius, action of my levator scapulae, and action of my serratus anterior. So they all come and play in that type of action because the movement around the scapula will be responsible above to 90-degree. Are we clear? Deltoid is not 15 to 90, 30 to 90, 20 to 90. Different book says different, and you should be. I don't remember 15, 20, or 30. I always say initiation is the job of supraspinatus. After initiation, what is initiation? You start your car. When you give a speed, when you apply pressure on your accelerator, then it goes boom. So that is beyond is the job of deltoid. So supraspinate is from 1 to 15 or 20, different books write 30. So these are, different ranges and there is no specific cutoff point. What attachment? Muhammad Ajlan, you are asking about attachment. Which muscle is responsible for abduction after 90-degree and up? I have just said it. Why you are not listening to me? Ashwan. Ashwana, I was just talking about that a minute before. Thank you. Noor is writing for you. Just to confirm, okay, fine. Let me say it again. Trapezius, serratus anterior, levator scapulae, all of them, they are working. But primarily, they are doing what? They are rotating the scapula. And then it is possible you can abduct more. If rotation doesn't occur, you cannot bring more. Latissimus dorsi is muscle of below. It's not, latissimus dorsi is helping in rotation of the scapula. Now, what is the function of bicipital aponeurosis? Guys, bicipital aponeurosis is, I have mentioned that will be helpful in medial rotation. So once we are bringing specific movements at elbow joint, at that time, bicipital aponeurosis is stabilizing. It's a detailed discussion. Let's not get in that. Supraspinatus, yes. 1 to 15, 1 to 20, 1 to 30. Anything you can say. Can we proceed? So now you're looking at biceps, you're looking at, guys, this is the short head, this is the long head, and this one which looks long to you, this is the short head. One which is medial is the short head, one which is lateral is the long head. And then underneath this, you're looking at this muscle under my biceps. This muscle is brachialis, and that is the strongest flexor of my elbow. Biceps is flexor and strongest supinator of my body. Are we good? Okay. So now let's proceed further. Now we are looking at back. Now you're looking at different muscle. Guys, this side you're looking at superficial layer and this side the deep layer. Are we good? So superficial layer, you can see this muscle. This is what my half of my trapezius. If I can draw it here like that, this is the complete what muscle? This is my complete trapezius. So this is my trapezius. Going further, now this one, look at it carefully. My latissimus dorsi. One half. I have latissimus dorsi on the other side as well. Are we clear? So this muscle, you can see that it's been attached to the spine and then thoracolumbar fascia. And then where it's going? It's going where? To my humerus. Are we good? So now you have seen the superficial layer. Now let's move to, I need eraser because I have drawn a lot here. Okay, so let's talk about, Guys, now I'll be talking about, these were the superficial, these are the deep. Because when we remove the superficial, then you can see the deep. So there, underneath, you can see number one, levator scapulae. Can you see that? This is my levator scapulae. Then you can see that rhomboids, major and minor both. And then, is that fine? Now, if somebody asks me intrinsic muscles, guys, these are the intrinsic muscles of my scapula. They are also deep muscles. So number one is on top of the spine, supraspinatus. Where is that? This one is supraspinatus. And this one is infraspinatus. Are we good? There you are looking at teres minor and teres major. So you can see that minor and you can see that major. Are we good with that? What's baby lati? What is that? Farah, what are you asking, baby lati? Okay, you want to call it baby lati, it's okay. You can call it anything. Intrinsic muscle, you will not say rotator cuff. You may, because most of them they fall in that category. They are basically what? They are localized to scapula, and they are working in a small circuit. They are not coming from other side. We don't call these rhomboids as intrinsic muscle, but they are coming from scapula and they are going in a very close vicinity within this cycle. Anything which is there, they are, you call them. But teres major is little bit out of this business. That's out. So intrinsic muscles from the upper limb to the other part of the upper limb. But this is, so what is the difference between intrinsic and extrinsic? I said it so many times, Ahmed. Intrinsic means dakhili, extrinsic means kharji. Guys, don't into this baby lats or adult lats. That will not be asking. What is ligamentum nuchae? Thank you asked this question. Now, to explain to you, I need eraser again because there is too much. I need to clean up this mess which I have created. So now I need pen again. So guys, can you see this white line? This is my ligamentum nuchae. Are you clear? So which one of the teres may we watch in anteriorly when we raise our hand? Obviously, this one is more prominent. Is intrinsic and extrinsic is the same as superficial and deep? Never. Intrinsic means they are localized in this area, and extrinsics are outside. So it is just supra and infraspinatus is the intrinsic muscle of the no. Subscapularis is also fall in that category. Should we know about specific attachment of the humerus? Yes, you should be knowing it. Extrinsic attached to the trunk. What trunk? What is the difference between proximal and distal attachment? Proximal means towards my caput. Distal means towards my foot, towards my tail. Not necessarily, because this intrinsic, when we go to the hand muscle, there I have an intrinsics, but there is no spine. You can hear the breathing better on the thoracolumbar fascia, right? No, that is, that triangle of thoracolumbar fascia. Where is the thoracolumbar fascia? Thoracolumbar fascia is somewhere here. Do you have lungs here? Gentlemen, you have kidneys here. Triangle of auscultation, you may find, can I show it to you here? This little triangle is my triangle of auscultation. Why I can hear nicely here? Because my lungs are here. There are my kidneys. Here are my kidneys. So my kidneys cannot make a sound. They can make urine only. What is the function of ligamentum nuchae? Is just a fibrous band where the muscle fibers are attached. No muscle also, so easier to hear with stethoscope. No, you can hear on top of the muscle, but it gives you more clearer. It's a window where you have no muscle there, but you have you have the intercostal muscles are still there. If thoracodorsal nerve is injured, is the only muscle that is affected? Obviously, primarily that one is gone. Can we proceed, guys, now? I think we talked enough about the things here. Okay, so now let me move this thing here. So, guys, now in this image, what you're looking at? You're looking at this quadrangular space, upper triangular space, and the lower triangular space. You need to be good with the boundaries, and you are looking at some of the contents of the quadrangular space. From this triangular space, what is passing? Radial nerve, profunda brachii artery, and here circumflex scapular artery from the upper triangular space. And there you're looking at the content of the quadrangular space. You're looking only the nerves. So there is my axillary nerve, there is my radial nerve. Can you see that? So only the nerves has been shown here. And this is what? Suprascapular nerves, and they are going in. And then posterior cord, it will give this axillary nerve, and then it continues. The terminal branch of it is called as the radial nerve. Then it goes down, reaches here. Then you can see that it becomes deep and superficial, passes between the pronator teres. Are we fine with that? Can you point at each of the space, please? Okay, I will do that. Relax. Let me bring up pointer. First, I need to bring a eraser because there is too much mess here. So now, guys, if you keep on typing, I'm just focused on one thing. So just see that, and then laser I'm taking. Now, guys, this is the quadrangular space. Quad means, look at it, one, two, three, four angles. Is it like a triangle? Musallath, Muthallas, Mustatil. So this is quadrangular. This is triangular. This is triangular. This is above, so we call it upper triangular, lower triangular, and quadrangular space. So if someone asks you what are the boundaries, so you can see that quadrangular space, superiorly you have what? Teres minor. Inferiorly you have teres major. Medially you have shaft of the humerus. Laterally you have the triceps. Which head of the triceps? So that these are the boundaries of your quadrangular space. Someone asks you the boundaries of lower triangular space, you can see that shaft of the humerus. There you can see this triceps, and on top you can see it is my teres major muscle. So this is how you should be knowing the boundaries, and you should be knowing the contents. No need to repeat, it's all been recorded, so you can hear that when you listen to my recording. So what we have to know, the borders of the triangle. Yes, you should be knowing the boundaries as well as the contents. Is axillary a terminal branch of radial? No, axillary is not a terminal. You can see that. Terminal means where it's ending, which is posterior cord. It gives a branch called axillary, and it continues as the radial nerve. Then the radial nerve, when it reaches at the elbow, then it becomes superficial and deep. Are we good? Alanud, what you're asking? Repeat. Takfa. What is that takfa thing? TAKFA. Or is a typo? Why does a cast affect the radial and not axillary nerve? Which cast? Can you specify your question? Takfa means please. Oh, thank you very much. I'm learning something great. Improperly fitted cast, So if I have a cast, usually, the question was, I know you're referring to the question of TBL today. So those were crutches. I hope everybody knows you wear your crutches in your armpits, so they can compress upon. Terminal is the last one. Yes, the terminal, it ends somewhere. No, it's okay. No need to be sorry. It's okay. I don't believe in sorries. Are we good? Can we proceed, guys? You can let me get an arrow. So why it is radial, not axillary? Because axillary is very deep. Radial is something which is close by. Axillary crutches means Auxiliary crutches means what? It depends on, it was written improperly fitted. So if you are applying, if the direction is towards the radial, then it will be affected. If it's towards the, so if you are directing towards some structure, then you can. Okay guys, so now I think I should proceed. Now here you are looking at, in surgical neck injury, does both posterior and anterior circumflex arteries get damaged or only posterior? Ahmed, if you go back to my presentation, you will notice that, and I think I've shown that image twice. If you look at the shaft of the humerus, let me draw it for you, because still you are confused, so I think you need to be. Now guys, just look at here. This is my a cut section of the humerus. Now this is my posterior circumflex humeral artery going all the way. And this is my anterior circumflex humeral artery. Now, Ahmad, tell me, if there is a fracture, who is more susceptible? Who has a long journey? Ahmad, I want answer from you. Posterior, thank you very much. That's why we use the term, but I'm not saying anterior. Anterior can be, it depends. If a chip of the bone comes and puncture here, it may damage the anterior circumflex humeral. It's possible. There's no rocket science. Are we good? Okay, so let's take the arrow thing, and then let's, okay, no, not arrow. I have to talk about this thing. I didn't talk about yet about this artery. So now you're looking at, in this image, what are you looking at? You're looking at here the axillary artery. You're looking at the axillary vein, and then you're looking at the brachial plexus. Look at its cords. So these are the cords of my brachial plexus, and this is the musculocutaneous nerve, and then this is the median nerve, this is the ulnar nerve. Posterior cord is being, so this is the medial cord. Posterior cord is hidden behind, so it's not being mentioned here, but you can see the axillary nerve is just going behind. Are we good? So yeah, this is what muscle, what it should be. This is pec minor, and this is the short head of the biceps, which is attached at the tip of the coracoid process. And you can see that this muscle crosses it. So many times we talk about, this is first part, this is second part, this is third part, one branch, two branch, three branch. I don't see anything. It will lead to internal bleeding. Yes, it will lead to internal bleeding, because unless you have a puncture, the blood will come out. But if there is no puncture, blood will not come out. Okay, do we need to talk more here, or you want me to proceed? Okay, you didn't allow, I'm just proceeding myself. So now, first of all, what you're looking here, a human body, look at it. This is the anterior axillary fold, and this is the posterior axillary fold. And this is what you're looking at. You're looking at the skin of the armpit. So this is the anterior axillary fold. So what I'm trying to show you here, I'm making what? My axilla. This is the anterior wall. That's the posterior wall. And that's the base, the skin of my armpit. So now we cut a section here. And this section, this is the front part. So this is the front part. You're looking at pec major and pec minor. Can you see this yellow thing? Guys, can you tell me what is this yellow thing? Who will tell me what is this yellow thing? No, it's not fat. This yellow thing. No, it's not axillary artery. I'm asking this thing, this yellow thing. No, I need a name of that. I want to see how smart you are. Perfect. So Momo Ari has come up with the right answer, and the right answer is clavipectoral fascia, and that's a very specific name. Momo, will you like to tell me what are those structures who pierces this clavipectoral fascia? Can you tell me that? No. This muscle is attached to the clavicle. It encircles subclavius. It descends down. It encircles pec minor. Then it descends down. But on purpose, I have not gone in these details. This structure is pierced by certain structures. Then there's a branching and rebranching, and this is the classic anatomy. Let's not get in that. Obviously, Momo, you are right. Now you are. So, okay, good, you know it. So these are the structure who are making the anterior wall of my axilla. Now posterior wall, you can see that subscapularis is shown, latissimus dorsi is there, and certain others. You can see that latissimus dorsi is being shown up here. And now the medial wall is only one structure, that's my serratus anterior. And what are the contents? Axilla, artery, vein, nerve. What nerves? These are the cords. You can see that. Why we call them medial? Because it's medial to the towards the body, away from the body. So it's lateral. Posterior to my artery is posterior cord. Are we good? Perfect. No, Osama, you need not to know this clavipectoral fascia in its detail. It was just a joke. There are so many things. We are not going in details. I said very clearly, you need not to go in details of clavipectoral fascia. Guys, are we good with that? Can I proceed, or you want me to spend more time here? Okay, I'm proceeding, but before I want to remove my mess. Where is my arrow? Here you go. Okay, guys, now what are you looking at? It's written here very clear. Yes. It's the cross section through the arm. So guys, this is the anterior compartment and this is the posterior compartment. So one muscle tells me all. This is my triceps. This is my septum, intermuscular septum. There's a medial, there's a lateral. And there are muscles. You're looking at the biceps. You're looking at the brachialis. And then you're looking at, what is that muscle? Brachialis. This is brachioradialis. Are we good? Because this section is deep. Can you see that? The humeral shaft has been becoming triangular. So that tells me I'm in the lower segment of the upper limb of the arm. If it was rounded, it could have been middle shaft. So it is down, so it's more triangular. Why is the extensor carparadialis longus here? Yes, because we are very close to the medial epicondyle. That's why. Asphia, now you understand why it's here? Because we are at the lower segment. Why is the extensor so, Asphia? I have answered you, cross section of the arm. So is that clear? I don't see any other thing in this image. Arrow. Okay. Now what are you looking at? Will we be required to identify the cross section of arm? Muhammad, are we reading? Are we learning it? If you are learning it, then we need to know it. And then it might be the part of your assessment. So anything which we are learning, we should be knowing it. Will we be required to identify cross section of the arm? I have just said it. Okay, I saw that. when you're writing, I was saying it. Isn't it just MCQs? Yes, this exam is only MCQs. So don't be bothered for these sections. We have OSPI and other thing, then there we'll be asking you. Don't worry for that. Relax. That is something for November. Now, guys, here what are we looking at? We are looking at the, we know this artery, axillary artery, and then giving its branches, becoming radial and ulnar when it reaches to the forearm, brachial, giving its things, anastomosis around the elbow. Dr. Sadia has spent good time on that. Oh, yeah, I love this question. Osama is asking, you think MCQ is easy? Guys, exam is always, what is the exam doing? Exam is separating exam is separating. Nothing is harder, nothing, because it's all about MCQ. You've been asked in different ways. So if you are regular, don't worry for that. It will be easy for you. We don't bring, we don't want to fail you. Listen, if we want to fail you, why we are doing these sessions? What benefit I'm getting, or my whole department is getting? So those who studied very nicely said, nothing is difficult. We are asking the same MSK. We are not asking about moon is purple or green. We are asking about the concept which we have learned, where we have spending time. Separating the boy from the men. Okay, I like it. I like Mariam. So your eyes are smiling. Okay, so guys, the same thing. You are looking at the brachial artery, its location, and you can see close by who's going. The median nerve is going close by. So we were talking about in the supracondylar fracture. What is the location for the supracondylar fracture? Here you go. So that's the location for the supracondylar fracture. So this is the place. Usually we get this fracture thing. So these are the structure who are more vulnerable and this fracture thing. So I think let's proceed further. Okay, now look at it. What happens to my ulnar artery and radial artery? Can you see that? My ulnar artery looks big. My radial artery looks small. Because why? Can you write me? Does the epithelium in the mouth require saliva so teeth should be sweating? No, that's a different story. It's a proverb. Don't get in that. Why does profunda brachial artery? What does profunda brachial artery supply? Guys, profunda brachial artery is also called deep artery of my arm. So it is responsible to supply the deeper structures. So, Asfia, what are you writing? Radial artery divides and ulnar does not divide. Radial artery is a terminal branch of axillary, so it is smaller. Why axillary? Why not brachial? Ulnar has superior and inferior ulnar collateral. It has more branches because ulnar going to medial. Ulnar artery has motor and sensory compartments. Listen, ulnar artery has more job to do. Radial artery, so it's all about utility. So there is more responsibility lying on ulnar artery. You know that ulnar artery, just when it reaches to my introosseous membrane, it bifurcates into common introosseous. And the common introosseous sends a branch which goes forward with the name of anterior introosseous, posterior introosseous. Then you are explained about posterior introosseous was giving recurrent introosseous, and that was going up and to be anastomosing. And then this ulnar artery, you will see tomorrow, ulnar artery is playing a major role in supplying blood. I'm saying a major role. I'm not saying radial doesn't supply there. So ulnar artery is primarily, it has more job to do in my hand. That's why it's bigger, because more blood needs to be traveled there. Doctor, how can we remember the vessel in the arm? What's so difficult in that? In the arm, you have the branches. What are those branches of the brachial artery in the arm, you have profunda brachii. Then you have very few nutrient and muscular, and there were two which was going down, two on this side, two on that side. Ulnar artery is lateral to the ulnar nerve. You can see yourself. Because when we talk of these terms, we talk with reference to anatomical position. So always remember, it looks to you, it's, if we place things in anatomical position, this is the lateral side. So this is lateral to my median. So you can see it here, it's going all the way down. Why aren't we focus on veins as much as we focus on the arteries? Wait, I have slides for that. Doctor, how to differentiate between arteries, nerves, and veins on a cadaver? Faris, come on, cadaver. When you are in a lab, ask your peer tutor. If he is not helping you, just write me the name of your peer tutor. Then I will request him to help you to understand that. And even if it's not working, come to me. I will cater you. Don't worry for that. We are here for your help. I think we should proceed further. Now, you're looking here what? You're looking here again the pathway of my ulnar artery, which has been shown here. You're looking at the ulnar artery itself, and then you're looking at the radial artery itself. It's been showing you broadly. We're not talking about intraosseous at the moment. You can see that when they reach to the hand, they are contributing some arches. So this is a deep arch and there's a superficial arch. So we call them deep palmar arch and superficial palmar arch. And that I'll be explaining tomorrow, inshallah, in detail. Guys, for tomorrow's session, come with good cup of coffee and good mental glucose levels and good sleep. Is there a peer tutor in lab group? If not, I have almost sent everywhere. So if you find that you don't have a peer tutor, just write to me. I have extra people and they have been promised with me. They will be helping you in that way. Nerves are compact and you will not feel find a lumen. Perfect, Ahmad. You are helping your colleagues. I like it. So guys, you can see here the pattern of the arteries, the main arteries and nerves in the forearm. Okay, let's proceed. So now this we you have talked about the anastomosis around scapula. Dr. Sadia has spent good time on that. Just revisit with those concepts so you can see that two on this side, two on that side, and then how and who contributes in making. What root values do we have to know? Root values of the major nerve. Nerves are coming up. Wait, relax. I'll be showing you. Now, somebody was asking me I should revise for him the boundaries of cubital fossa, and I told that person when it will come, I have a slide for that. Now, just see it here. Guys, now just see here. In short, the forearm, what are must thing to know? In forearm, must thing to know flexor compartment muscles and their innervation and their nerve supply and their actions, and you should be able to identify all of them on the cadaver, on the images, everywhere. Posterior compartment, all those muscles. You cannot see the deep one, but you can see, you can identify very easily. The arteries and nerves very clearly. Compartment syndrome very clearly. Now, so now let's talk of cubital fossa. Guys, I'm drawing a line here. I call it an imaginary line. Because it's an imaginary. Can you see a line in your forearm or in your cubital fossa? Nobody can. So this is the medial side. So this is, you're looking at the medial epicondyle. Are we good with that? And this one on this side is not been shown, the lateral epicondyle. So now, can you see that? A muscle here called brachioradialis. Guys, don't write anything. Why we don't focus on extensors as much? We do. Who says we don't focus on that? But extensor you cannot see much on the cadaver because there are so many deep. But the flexors are same. And we are telling you we were going accordingly things. So now just focus. Look at brachioradialis. Is it lateral or medial? This is medial side. So this is making the lateral boundary. And then who's this muscle? This is my pronator teres. So pronator teres is making my medial boundary. And brachioradial is making my lateral boundary. So I'm getting at the end of what? I'm getting a triangle like thing. And who's making the base? This imaginary line, which which runs from my medial epicondyle to my lateral epicondyle. Now, what are the contents? So, contents, you can see the tendon of the biceps, then you can see the brachial artery, and then you can see the median nerve. Can you see them? If I spread this out, you can see the more deeper structure, but these are the broad contents. And then in the roof, I have deep fascia, and in that deep fascia, we have some muscle. We have some vein, superficial vein that is crossing over. And then in the floor we have bones, and then we have muscles, brachial. So all those things that has been shown and that has been shared with you. I hope I was able to answer your question, which was asked me earlier. So now this is more elaborating what has been said so far. So now you can see that the medially placed is the median nerve. Then there is a brachial artery. It's lateral to that. This is the radius. This is the lateral side. This is the medial side. So you can talk in reference to that. And there you can see in the floor, you have the brachialis muscle. And then more superficial, this is a deep one. And this is the more superficial, you can see the tendon of the biceps. Here the tendon of the bicep has been removed. So this is the biceps, underneath is the brachialis. There is the bicep, underneath is the brachialis. And then, if you expose it a lot, then you can see these things, the posterior interosseous nerve, the radial nerve, it's branched off and it passes through. But these are the deeper dissection. But here it's quite superficial. Are we good with that, or you want more elaboration? So memorize the content by knowing that nerves are in both sides, and but first of all we should be knowing the contents, and then if I spread it out, if I stretch it out, I like to see the I will be finding more structures here. Are we good? Okay, now let's proceed further. So now this is what you're looking at. I have just said before. So you can see that the radial artery, what happened to the radial artery and what happened to the ulnar artery when they enter my hand, my palm. This is the palmar side of my hand. This is the palmar side, and this is the dorsal side. So most of the things are occurring on the palmar side. So now what is happening? You are looking at a deep arch. This is my deep palmar arch. And who's making it? My radial artery is contributing for that. And this is my superficial palmar arch. You can see that the superficial has too much contribution, and the deep palmar arch, it blends with that. So this is my superficial arch. And who's the main artery for that? The superficial arch is made by ulnar artery, and deep arch is made by radial artery. Superficial means it's superior, and deep means it's inside. And you can see these are the digital branches and which are supplying to my digits. We'll be talking in detail about that. Will this session be posted on YouTube? We will see that. Don't worry for that. I will do everything which can help you. Be rest assured. And I will not let anybody without knowing things unless somebody has not decided to learn. Can you repeat, please? What should I repeat? Superficial arch, look at it. Deep arch. Who makes my superficial arch? Ulnar artery. Who makes my deep arch? Radial artery. The arch seems like radial and ulnar branches merged together. I will show you tomorrow. Relax. This is just a picture. Arches, relax tomorrow. 8 to 10. Come with energy. I will talk all about hand. It's a very loaded session, full of infos. So now, who was saying we are not emphasizing on veins? We have, Dr. Sadia has spent good time in talking about veins, and be reminded, we always learn there are superficial veins and there are deep veins. So you're looking at the cephalic and basalic. Never forget basalic, it's medially towards your pinky, and cephalic towards your big, first digit, thumb, and then this is going deep in. So the superficial vein runs under the skin. There are so many functions for those. And now these, and along with my arteries, the main arteries, I have a same name, veins are running, and they are always two in between is the artery. So they are called vena committents. Vena committents of my radial artery, vena committents of my ulnar artery, vena committents of my brachial artery, and all superficial and deep veins join to form what? My axillary vein, and that is being becoming subclavian, and then it's joining from the above, and this is how it goes. Hand is included for the midterm. Yes, my dear. Lecture number 15, it was made clear in the main presentation which was sent to you. Whole upper limb will be part of your there, part of your midterm. Are the veins are important to know as arteries? Yes, my dear. You should be knowing about them, but they are very simple, cephalic and basalic, and then we have vena comitant. Cephalic goes to the side of the, you can see that. Cephalic is here, and this is my thumb, and basalic is here, and this is towards my pinky. Are we good? Yeah, I like that. I like this presentation. Nasir, what you're sharing is good. Deep veins have, yeah, deep arteries have veins, and the veins are on both the side. So they are called, let me draw it for you. Just see here. This is an artery. Bear with me with my poor drawing at the moment. So now on both the side of this artery there are two veins and they are connected with each other. And these veins are called vena comitants. So we only know the basalic, cephalic, these are the superficial veins, and then they blend with these deep veins, and ultimate thing is the end product is what is my axillary vein. So they are the main ones, but not only. Median vein plus basalic vein, yeah, it was emphasized a lot. I saw Roxadia was spending good energy and time on explaining that. Okay, so let's proceed. Now, look at it. We talk about which nerve is this? Posterior interosseous nerve is a branch of what? It passes between supinator. So this is my, which nerve is that? Radial. Thank you. You guys are smart. Why you're scared? I can see that you're scoring good, mashallah. Fine. Now what do you think here? It's written here. So please look at it. This is clavicle, which is fractured. It's not necessary fracture means it's going apart. Look at it. It's connected, but this end is breached. Let me draw it for you. Can you see there's a rent here? Can you see this bending? Let me erase it. You like to, I like you to see it again. Now, let me take an laser pointer. Yes. Now guys, can you see that if you just follow this thing, this goes and there's a rent here and then it goes. And do you think clavicle should be like that? Let me draw this clavicle, how it looks to me. Where are you, my pen? Look at it. My clavicle, have you ever seen a clavicle like that? Any of the lab session? How is that? So this is I have just made fracture for you. If I remove it, you can see everything again. Look at it. Everything is shown to you. Are we clear? Okay, let's proceed because I have a lot to cover. It sounds separate from the acromion. Yeah, it looks to me, but not really that much. Is the lecture about the nervous system that we will be take this week is in the exam? No. Only lecture number 15. Doctor, can we revise the snuff box and the carpal tunnel? Yes, they are coming up. Doctor, could you please explain the snuff box? Yes. Shaza, I will be explaining about that. Relax. Okay. So now you're looking at a shoulder joint, a section of a shoulder joint. So let's try to identify. I think I can take a pen here. So you're looking at, what are these structures? This is my acromion, and this is what? The clavicle. Can you see that? So acromion and clavicle, they are connected at this place through acromioclavicular ligament. Are we good with that? So this I'm drawing here is the acromioclavicular ligament. Now can you see these ligaments? This is said trapezoid, and this one conical is called conoid. and they are coracoclavicular ligament. Why they are called coracoclavicular ligament? Because they are connecting coracoid process and the clavicles. So they are in between these two structures. So they are called coracoclavicular ligaments. And one part which is flat, quadrangular, we call it trapezoid. Other conical, we call it conoid. Are we clear? So now, if these ligaments are damaged due to some fall, so this clavicle, what will happen to this clavicle? This clavicle will be released from here. And if this ligament is also gone, because trauma is so much, so my clavicle will be raised laterally. So now this will be separated. So that's called separation. Okay. So let's erase this mess. Where are you, eraser? So everything is gone. Okay. So I need pen again. Now see here. This is my fibrous joint capsule. Can you see inside this fibrous joint capsule? I have inferior, middle, and superior glenohumeral ligaments. It has three components of it. Why it's inferior? Because it's inferiorly placed. It's in the middle, we call it middle glenohumeral ligament, and it's on top, we call it superior glenohumeral ligament. So they are inside the fibrous capsule. So these all are, who are these? Fibrous capsule, superior, middle, and inferior glenohumeral ligaments are the ligaments of my glenohumeral joint. So many of you were asking me, I saw in my inbox, you were asking me, so these are the ligaments of my glenohumeral joint. So now this coracoacromial ligament is just above to that. So this is out of my glenohumeral ligament. This is my subscapularis muscle, and there is the bursa, which is preventing friction here. In front, I have infraspinatus. So on the back, I have infraspinatus. Above, I have supraspinatus. Why? Because this is the spine. There is the spine. So the spine demarcates supraspinatus from infraspinatus. Are we good? So now this ligament and these bones, they are making an arch, a very strong arch, which prevents upward dislocation of the head of the humerus. So these are those factors which are very strong, a bony fragment as well as a ligamented segment, and they are preventing upward dislocation. That's why it's very rare, unless you had a very strong power which really bangs here and this whole head of the humerus pops up. That's a very different thing. Are we clear? Okay. So the same concept has been revised here. You can see that the long head of the biceps travels all the way, enclosed in a sleeve, passes between the bicipital groove, get inside and blends here. Look at this glenoid cavity. It has been reinforced by this fibrous collar. We call it glenoid labrum. This is the glenoid labrum. This is the glenoid fossa. And the job of this, and this is the capsular attachment. This pinkish thing is called glenoid labrum. And the job of these things is or to, to deepen, to increase the depth of this glenoid fossa. So the head of my humerus, which is well circumfered, and if I see the glenoid cavity is very shallow. So how I can make it deep? So I can reinforce it by some structure. This is my glenoid labrum. Then I attach the fibrous capsule, so that becomes a cup, and this head fits in nicely inside. So guys, I think we spent good time on talking about the shoulder joint and its different ligaments, and I don't think there is any problem. So only the, so let me scroll through. Only the three glenohumeral ligaments are for the glenohumeral joint. Don't say glenohumeral ligaments. Three glenohumeral ligaments plus fibrous capsule, they are the ligaments of, always capsule is also a ligament for that. Separation, the ligament is damaged. Dislocation, the bone is moved out of its place. Excellent, Lean, you're right. So now dislocation, nothing is treated or separated. It's only dislocation. Dislocation, nothing. Noor, I didn't get it. What you're saying? Where is the coracohumeral ligament? Is it outside the joint capsule? Yes, coracohumeral is outside because it's connecting. You are saying yourself, coracoid and humeral. So this is outside, coracohumeral. So it's between coracoid and humerus. So no, doctor, what about the coracohumeral ligament? I just said about it's about the so it's outside that. Is the coracohumeral ligament part of the glenohumeral joint? It's between, people count it as, but it is outside my fibrous capsule. Are we good? Because if you want to take that coracohumeral, then you have to take coracoacromial, then you have to take coracoclavicular, then everything has to be taken. So not only three, these three plus the fibrous joint capsule. Fibrous capsule includes the glenohumeral. Yes, fibrous capsule is always a ligament. If somebody asks you name the ligament, transverse humeral ligament is just what? Transverse humerus ligament is, just look at this. This is the tendon of the long head of the biceps, and it passes through bicipital groove. This is the bicipital groove. Now there are chances that it slips down. So this transverse humeral just crosses over. So it maintains this long head of the bicep in its place. So it's placed transversely. So it's not that. So to keep the long head perfect, you guys are right. Anchors the long head. Excellent. Malik, you are right. So let's proceed. Okay, guys, this is a very important concept. You should be good at it, guys. We love to ask this concept a lot. And this is the same diagram, same MR, and this is the image of the same MR. You're looking at what? Supraspinatus. Look at it. Acromion, bony landmark. Look at the head of the humerus, glenoid fossa. So this is bone. Let me draw it. This is bone. This is something bone. This is something bone. Now, this tendon of my supraspinatus goes from here. Getting it? To be attached. So now there is a bursa here. But still, so too much movement, abduction. Can you tell me how many times you have done abduction at your shoulder today? Do you remember that? No, I don't. Maybe you are. Wow, I loved you. Dean, you are saying, who's saying? Abdurrahim is saying 6778. Why not 1778? 132. Wow. Sammy, I love your answer. I can say infinity. We cannot count. Excellent. So, if there is too much wear tear, anything which moves a lot. Okay, let me take you back to the journey. You remember when these cell phones arrived, they were having some flip type of thing. Why they removed those models? Because those flips, after some time, they got damaged. So now you don't find those flip things. The same is there. We move this a lot. The shoulder joint, there is too much mobility. So anything which is moving too much is more susceptible to be damaged. So this tendon, with so many changes, friction, wear, tear, everything, this is gone. If this tendon is gone, we can have the inflammation of this bursa. We can have the inflammation of this tendon, tendinosynovitis, tenosynovitis. So many things are occurring. And once we have painful condition here, so my abduction at the shoulder, flexion at the shoulder, extension at the shoulder, adduction at the shoulder, circumduction at the shoulder, everything is now painful. So I have a painful arc syndrome. A pain is there. So this pain has to be, is troubling what? Our glands. When we grow old or when we are super weak. So we have excellent, somebody's writing, Noor is writing, painful arc. How can a question come about this concept? Wow, I love you. Send me your inbox me, I will tell you. Yes, but bursa is also susceptible to be for damage. Yes, bursa is to be damaged. So they are interconnected. They are so close, so they can be affected. Are we good? Which tendon exactly gets damaged? The tendon, this tendon. I have messed around. Let me erase my mess. Where are you, eraser? Now, who was asking me which tendon? So let me show you that tendon. Eraser. Can you see that there is a tendon going here? That's this one. So tiny space. And above to it, what I'm having this, even this one is coming here. Long head of the bicep is also coming here. So in between, there's a very tiny space for that. Deltoid is covering on top. So now, sorry. So this one is my, look at it. This one is coming here, long head of the biceps. Then this supraspinatus. And then this deltoid is there. So it is sandwiched. There are bones, there are ligaments. You know what? It's very interesting. Most of my joints of my body, the bones are there, and then they are enclosed by ligaments and by muscles. But here what happens? The muscles are trapped between the bones. You look at your knee joint. Inside are the bones and outermost are the ligaments and muscle and everything. But here, these are few muscles which are trapped in between these bony landmarks. So space become very narrow. So in a narrow space, if you have to drive your car from a very narrow point, and there are fair enough chances. So there are fair enough chances if you're going in a speed, you can cause some damages. Are we good? Okay, now let's, guys, but spend good time on this concept. Are there any nerve and artery damage could happen in pain? No, usually not. But the impingement of axillary nerve is also been denoting to the painful arc syndrome. Doctor, where can I find your question box? Sami, just click this everyone and right click, and then you can enter. You can write to me. That's. Can you repeat exactly what is damage? Wow, I love it, Al Bayat. So you can listen to my recording. That will answer you. Okay, guys. So now tell me, what is the heart? What are you looking at? What is the situation? Dislocation. Excellent. Dislocation. Dislocation. Yes, I love you guys. So you can see very clearly what you see here. Where are my pen? Yeah, here is my pen. So now, guys, look at it. The head of the humerus has came down all the way, and it is addicted. The contour of my shoulder is lost, and this was the place where it has to be. So it has moved, it has shifted all the way down. Can you see that? Anterior, inferior. Yes, Noor, you are right. Muhammad, you are right. So all of you are right, guys. You are smart. Why you guys are bothered? I don't see you're losing anything. You guys are smart, mashallah. And I wish, I can pray, if you keep this energy, if you keep this much thing, nobody can fail you. And we never want to fail you. But now what is very interesting, only 154 people are with me. So those who are chilling and relaxing and they are more busy in other things, I can wish good for them. Okay, Alhamdulillah. Thank you very much. Tala, they are missing out, then they will complain. Oh, this was not covered because you are not there. So, out of a class of 450, if 154 are with me, fine. Enjoy, let them enjoy. What Abdul Jabbar was showing today, the figure. So, that explains everything. Mohammed, we try always to make things easier. So guys, now we are now entering where? To the elbow joint, and you can see that this is a lateral view, this is a medial view. Simply, no need to go in details. This is anterior band, posterior band, inferior band, medial band. Simply lateral ligament, medial ligament, radial collateral, ulnar collateral. This is the joint capsule, and this is all inside. Everything is covered. So this is my elbow joint. I told you the articulation between the capit and the capitulum and the head of the radius, the trochlea and the ulnar notch or the trochlear notch. So these are two articulation, and then the superior. So this is the annular ligament, and that makes my proximal radio ulnar joint. Doctor, what radio ulnar joint has two ligaments and the elbow has four? Guys, don't go in numbers. You can see yourself. What you can see, I can see three only. One is lateral ligament, medial ligament, lateral ligament, and the fibrous joint capsule. Who says four, three, four, and five? So these are only three. And for my proximal, I can see only one, and that is the annular ligament. Yes, joint capsule is a ligament. So what I'm saying, a lateral ligament, a medial ligament, and a joint capsule. So how many are together? Three for elbow joint. And for my proximal radio ulnar, so annular ligament is there. Do we need to detail other ligaments than annular? It's okay. So now this dotted image is just showing you how this fibrous joint capsule is being attached. I think Dr. Ayman spent good time on telling you why it's been here and what is happening. So I don't want to repeat that thing. Now, in the forearm, we talk about its layer by layer concept. You can see what? Pronator teres. Then flexor carpi, ulnaris. And then who is this? Palmaris longus. And who this should be? Flexor carpi radialis. So pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. So this is the superficial layer. Intermediate, flexor digitorum superficialis. Deep layer, flexor digitorum profundus, flexor pollicis longus, and underneath is the pronator quadratus. So that completes my flexors of my forearm. But guys, only names are not enough. You need to know their actions. And actions are not really difficult. All of them are what? Flexors and supinators. That's it. Pronator syndrome is what? When median nerve is compressed between the ulnar and the humeral head of the pronator teres. Yes, that's what. Okay, now what I'm showing you. This is something which is connected with tomorrow. In this image, you are looking at in one image where I can see palmar adduct. So my fingers are like that. So what is this? This is abduction and this is adduction. So I have an intrinsic muscles. They are called introssei. On one set is on the dorsal side. They are called dorsal introssei. There is a palmar introssei. So they are helpful in abduction and adduction. I'll be talking about them tomorrow. And the middle half of the FDP, they all are flexors supplied by median nerve except flexor carpi ulnaris and the two heads, the fourth and fifth digits of the flexor digitorum profundus. There's no dorsal introsseus in the middle finger. What is dorsal introsseus? Yeah, we will talk tomorrow. Just relax, lean. Otherwise, people will be confused. Now, guys, this is something which you need to understand. Please stay focused now. What I'm trying to show you here, let me remove this. Now, look at here. This is an image of hand, and you're looking at two nerves, ulnar nerve and median nerve. We learned that the median nerve was passing through carpal tunnel, and this is my flexor retinaculum. And under this, I have this median nerve. When it comes here, you can see that it supplies, but its motor supply is very minimal, but it has more sensory supply because its motor part is only this much. It only supplies to the thenar eminence muscle. That is its motor contribution. And these are all are sensory. They are going to my digits. And then this ulnar nerve, it has to do a lot here. It supplies through its deep branch hypothenar eminence muscles. Then it supplies lumbricals, it supplies introssei, it supplies adductor pollicis brevis muscle. We talk about adductor pollicis longus, but now we'll be learning tomorrow adductor pollicis brevis. So there are so many muscles, thenar and hypothenar. This concept has been explained in the lab. So now let's remove the muscle. Let's look in here. Now this image is showing you the distribution of what? The ulnar nerve. Look at it. Ulnar nerve comes down, supplying here, supplying my hypothenar eminence muscle. Then it's going and supplying. It has less sensory contribution, but more motor contribution. And my median nerve has only this branch, recurrent branch of my median nerve supplying the thenar. This is the only motor nerve. So all these are sensory nerves. So it has more sensory distribution than an ulnar nerve has less sensory contribution than more it has. So if somebody asks me the main nerve of the hand, I think I have put this question also That is a different way. I will be explaining that. But this ulnar nerve is supplying most of the muscles here. So this is the distribution of my ulnar nerve, and this is the distribution of my median nerve. So median nerve is supplying thin R eminence muscle. There are three, and ulnar nerve is supplying hypothenor plus intraossei plus two of the lumbricals. So it has more muscle to be supplied, and it has less nerve, less sensory supplies here. But my median nerve has more sensory, less motor. Are we good with that? Let me check in the chat box. So the main nerve of the hand is ulnar nerve, yeah, in term of muscles. But sensory sensation, it's more for median. Are we supposed to know the branches of axillary nerve between? Axillary nerve, why you're talking axillary nerve here? Axillary nerve was in the shoulder. Medial lumbrical 3, 4 are supplied by ulnar. Lateral are supplied by 1, 2. Yes, perfect. Ulnar nerve and median nerve in opposition, in opposite. Yes, sure. So let's proceed. Are we good so far? Or you want me to talk more? Doctor, if your time allows, can you please give an overview of the elbow anastomosis? Sure, I will. Can you repeat which is motor? And I listen. I will be repeating, Abrar. I'll be repeating this the about hand in detail tomorrow. So just relax. Don't get, don't get nervous. Oh, it's a lot, and all of them, all of a sudden, it's been bombarded. No, be rest assured. And I'm not the one who don't believe in justice. We will try to challenge you as much you can be challenged. We are not making some ditch for you. We are trying to help you. So be rest assured the help is there. It's not a problem for you. Now, people were asking me about anatomical snuff box. So here you can see, guys, anatomical snuff box. When we're talking about a box, always remember a box, this is a box. It has what? A floor, a roof, and a floor and walls. So same is applicable here. Now look at it in this diagram. You can see that there are some tendons. Tendon of my extensor pollicis longus making one wall, and the tendon of my abductor pollicis longus and brevis making the other wall. So these are the boundaries. Then floor, you can see the bones, styloid process, scaphoid, trapezium, they all are contributing to the floor. Even this muscle is also coming here. And then this cephalic vein runs in the deep fascia. What is the content of my snuff box, anatomical snuff box? Only one content, and that is the radial artery. Radial artery, we all know it runs here, it gets in here, it pierces this muscle. This is, you're looking at first dorsal intraossei. It pierces this muscle, so it reaches to the palmar side of my hand. So this is the, let me draw it for you. So now this small triangle which I'm about to make here, that is my anatomical snuff box. So you should be knowing who makes the boundaries, who makes the roof, who makes the floor, and what is the content. Content is one only. That is the radial artery. Are we good? Okay, guys. So why is that when a supracondylar fracture occurs, the person cannot form a fist if the median nerve is technically more sensory than motor? No. How about when you make your own fist? Make your own fist. See that how many muscles you are using. Flexor digitorum profundus, flexor digitorum superficialis. What are they doing? Are they not making your fist? And who's controlling them? Median nerve. These intrinsic muscles are more used for your fine activities, but the power is dependent on these flexor digitorum profundus and flexor digitorum superficialis. So median nerve is predominating here. You mentioned in your slide that extensor carpi radialis brevis is innervated by posterior intraosseous nerve. While in gray it says, send me which gray you're talking. I love to send you a snapshot from the grays. Is there a nerve in an anatomical snuff box? Yeah, superficial branch of my radial nerve. It runs in the roof of the anatomical snuff box. It's not as the content of the snuff box. We can pulse radial artery in two slides, lateral to FCR tendon and against scaphoid in snuff box, right? Yeah. So it is the median nerve. Median nerve is here. Median nerve is in this place. Median nerve is here. So flexor digitorum is extrinsic. Yes, perfect. Kaniz, you are right now. So the extrinsic muscles are flexor digitorum superficialis and profundus, and intrinsic muscles are these tiny hypothenar and thenar eminence muscle. Perfect. So let's proceed. Now, you're looking at the carpal tunnel. Guys, today you guys were confused. You're talking, this was the volar ligament. This is the volar fragment. And the question was, who makes the anterior wall? That is the flexor retinaculum. This is the flexor retinaculum. And this volar carpal ligament is this one. And these are the structures who are present in my carpal tunnel, because these are different levels. So you're looking at the tendons of superficialis and profundus. They has been, they have been shown, and the flexor pollicis longus. So these tendons have been tightened up, and then we'll be learning about what happens. And today Paul was inquiring about when people were not able to connect that what happened and what are those findings. He brought a concept of ape hand and everything. I'll be showing you tomorrow. So median nerve is more significant. Yeah, perfect. I agree with you. And okay. So I think we talked enough about that. So the never mind, but could you show the volar again? Yes, I don't mind. This is the volar. Let me write it for you so you'll never forget. Sorry for my this writing. It's not easy writing from your mouse. So this is the volar. Are you good with this volar thing? This is the volar. Flexor carpi realis. What is that, Abdullah? Carpal tunnel only flexor muscle. No, never. It's on a flexor side. Extensor side is this, my dear. This is extensor side. So how you bring these extensors here? So the only nerve which is affected in the carpal tunnel is median, because this is the median only inside. Who's inside? This is only inside. Ulnar is outside. Why it should be affected? Ulnar artery is outside. Purpose of the volar is one fragment of my flexor retinaculum. What causes carpal tunnel syndrome? Go back, Salma, go back. And just so many times it has been mentioned. So why it means that you're not reading your slides. Why you want me to say it again? Just open it. Answer is there. Okay, so what is the most common fracture in the carpal bone? Scaphoid. And lunate is the most commonly dislocated bone. Ulnar is out of the tunnel. Perfect. Is flexor carpi radialis part of the tunnel? Never. You can see it is outside. You can see it here. Flexor carpi radialis is lying outside. It's not. Let me use the eraser because you guys are messing up now. Now, let me draw it for you. Guys, this is carpal tunnel. Now tell me who's inside and who's outside. You are asking flexor carpi radialis. See it very clearly. It is outside. Ulnar nerve, ulnar artery outside. No other tendon. Only 4 and 4, 8 and 1, 9. So these tendons, these are the only structure who are inside. Let me put them in a box to make your life easy. These 8 tendons and this one. They are only inside plus median nerve. They are inside the carpal tunnel. They can happen separately. Obviously, there is a partition in between. So no arteries damage in carpal. Never. Can you see any artery? Show me any artery here. Cephalic vein is deep fascia, is roof of the snuff box. Yes, very true. Volar is the lateral part of the flex. No, volar is a slip. You can see that I've just shown you. This is the volar thing. So this is the question was who makes the anterior boundary? This is my carpal tunnel. If anything is lateral to it, why you're bringing it as the anterior boundary? So guys, we have a lot to do, but still. So now this is the wrist joint. We'll be talking about it. So I think we are okay. Now these are the extensor muscles. We talk about them. We have superficial and deep has been shown to you. You are looking at the brachioradialis, extensor carpi radialis, longus, brevis, and then you have extensor digitorum, and then the deep muscle supinator and those abductor pollicis longus, extensor pollicis longus, brevis, and then extensor indicis, which has been shown up here. So going further, you can see these muscles. I have shown you. I have talked about them. You can see this which nerve, posterior interosseous nerve. It pierces the supinator muscle, and then it supplies here. It's the deep branch of my radial nerve. Now this is the brachial plexus. We are good with that. Yes, let's quickly revise. So this is you are looking at ulnar nerve. You can see that ulnar nerve is coming. It's going so close. It's medial to my ulnar artery. Are flexor rotator volar carpal ligament are the same? No, so they are not the same. Volar carpal ligament is part of the flexor retinaculum. Thank you. Those who are saying Osama and Lean, no, no, no. I love that. So now look at it. Follow this ulnar nerve. It comes from it's a continuation of my medial cord of my brachial plexus. It has no contribution in the arm. Can you see that? It goes close to flexor carpi ulnaris. It goes behind what? Behind my medial epicondyle. And then it supplies flexor carpi ulnaris muscle. And what else it supply? It supplies to my two digits, digit 4 and digit 5 of my flexor digitorum profundus muscle. And this is its supply. And these are its cutaneous branches, sensory branches. And look at it in the hand. It has so much motor supply. So it has a major contribution which is done. So would golfer elbow hurt the ulnar nerve? Gentlemen, golfer elbow, yes, it will hurt. And the tennis elbow is somewhere here. I hope we talk about. And you can see that even it supplies hypothenar, then it going and supplying to the adductor pollicis, which is also controlling my thumb, but its nerve is ulnar nerve. So I have given you a comprehensive overview of my ulnar nerve. Is the extensor carpi radialis longus part of the common extensor tendon? Yes, because it's one of the side it was shown outside. No, but it is part of that. Are we good with the ulnar nerve? Any question? Tennis lateral side, yes. Golf medial side. So guys, now you're looking at the median nerve. Look at it. It has no contribution in the arm. It enters in the, it reaches in the middle part of my forearm in the cubital fossa. Then it enters, it gives it anterior interosseous, and then it supplies thenar eminence muscle only here, and then it has all sensory contribution. So we only have one adductor for the thumb. Yes. Now the radial nerve, you can see that passes through the radial groove. Mid shaft fracture, we talk about that, accompanied with this profunda brachia. You can see it again. Then it coming, supplying what? Only one muscle in the extensor compartment of my arm, and that one branches to the triceps. And then you can see that it gives a posterior sensory branch, and then it divides into superficial. So this is a superficial branch, and this is a deep branch. We call it posterior interosseous. Look at it. This superficial branch is the one which runs in the roof of my anatomical snuff box. Do we have to know intrinsic and extrinsic muscle of the arm and forearm? We don't really categorize them. We call them superficial and deep. Extrinsic and intrinsic terms have been used more precisely in the palm and around the scapula. We are not using it a lot everywhere because there it makes more sense. So, guys, that completes our today's discussion. A lot is there, and I'm open for your comments, your discussion. Dig out more. I have tried to go over, but you know that sky is the limit. So Tuesday, same time, 7 to 9, I'll come up with more things. But you ignite the fire. You have to send me the questions, and then I'll be helpful for you. Guys, we wish, pray, and just we like to see you going with a happy smile. I don't want to see anybody losing any mark or failing any of your exam or any of your MCQs and everything. And I hope you will be going over what I have tried to spend in these 2 hours, and I'm sure it will help you a long way for your good endeavors of your life. And I wish you all success and see you on Tuesday. But I like to see more people. Fine, those who are not interested, I don't care for them. But listening to me face to face, direct interaction has a better impact than listening to the recordings. Thank you very much. Love you all. Stay blessed, stay safe, stay home. Thank you. Bye bye. Bye bye. Leave.